Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series I will be speaking with Manchester cancer researchers about their innovations, discoveries and projects that are changing the landscape of early detection. In this episode, we speak to Dr. Jen Davies-Oliveira and Professor Emma Crosbie about their research into womb cancer and human papillomavirus, commonly known as HPV. We also discuss one of their research projects developing alternative self-sampling methods for HPV. With lower cervical screening uptake in communities such as the LGBTQIA+ community, we explore how addressing barriers to screening can be achieved through greater engagement with these groups and the importance of developing an inclusive approach to screening. Jen and Emma, hello. Thank you for joining me.
Hello.
Hi. Thank you for inviting us.
How are you both doing?
Fantastic.
Really good.
Really good, not too warm.
It is quite warm today.
It is very
It
warm
is heat
today.
wavy.
It is heat wavy, but it's fine. We will ride the wave, as it were. So to start with, would you both be able to introduce yourselves and what it is you do? Emma, I'll come to you first.
So I'm Emma Crosbie. I'm a Professor of Gynaecological Oncology at the University of Manchester. And essentially that means that I've got the best job in the world because I spend half my week looking after patients with gynaecological cancers and half my week doing cancer research.
And Jen.
My name is Jen Davies-Oliveira and I'm a PhD student with Emma's lab at St Mary's Hospital, and I have taken time out of my clinical training. I am an obs and gynae trainee and I absolutely love being a PhD student in Emma's lab, mainly because of Emma, but also because I have a fantastic project which we're going to hear all about.
So, Emma, I'm wondering if you would be able to provide us with an initial overview of cervical cancer incidence and causes.
So cervical cancer is caused by high-risk human papillomavirus infection. So this is a really common sexually transmitted infection that affects around 80% of us. And this virus causes infections that can persist and become precancerous lesions, and then with time, in a rare group of people, can become cancer. So essentially, it's a really, really common virus, but a very, very rare consequence of infection with that virus. And this understanding of the biology underpinning cervical cancer has allowed us to develop screening and prevention programs.
Okay, and I'd like to kind of touch on some of those screening and prevention programs. Just something that I read the other day was that 99% of cervical cancers are caused by HPV. Is that right?
Yes, that's right.
So that's a really high statistic. And then what is the other 1%? Is that just kind of general genetic
Probably.
abnormality?
Yes.
Interesting. Okay, so I personally know that you've worked in HPV in Manchester, and I'm wondering if you'd be able to explain what this work has involved in the past and the outcomes that we've seen from it.
When I was a PhD student here in Manchester, I was working on the HPV vaccine, which, as you know, has now been rolled out to school-age girls in the UK and more latterly to school-age boys. And this vaccine protects against HPV infection. So the reason that we give it to young adolescents is that we want to give it to people before they have been naturally infected with the virus, because that is the population in whom it's likely to work best. So when I was doing my PhD, I was looking at the HPV vaccine, and we were applying it to people with another condition called vulval intraepithelial neoplasia, which is essentially when the precancerous changes affect the vulva instead of the cervix. And that was the nature of my PhD. I was looking for immunological responses to the vaccine and looking to see whether or not people with VIN cleared their disease when they were vaccinated.
Okay, so 14 Gs of the base rate, so that's like pre-kind of sexual, what would you call it?
Sexual debut.
Sexual debut. We'll go with sexual debut. And I mean, I personally remember when I was 14 having that. I don't even think I really knew what it was for. I don't think it was explained that much. It was just you were administered HPV vaccine and it was kind of you rather than the boys and things. And I'm just wondering, because I can't remember, but when was it routinely rolled out? Like, what year was that in?
So in 2008, the government started to give it to girls aged between sort of 12 and 13, but they had a catch-up programme where they offered it to girls up to the age of 18 because they didn't want people to miss out, for it just to be because of their age that they had missed out on this really important opportunity for cervical cancer prevention. So since 2008, we've been offering it in a schools-based immunisation programme to girls. And then just last year, we introduced it to boys as well. So it's now a gender-neutral HPV vaccination programme. And essentially, the whole idea behind this is to try and prevent anybody from developing an HPV infection in the first place. And if we can prevent the infection from happening, then the idea is that we will prevent the consequences of that infection, which is the precancerous changes that I've been talking about, and also, of course, cervical cancer.
Okay, so it makes sense as well for the fact that boys are receiving it, because I'd kind of think that they'd be a conduit and pass it on to girls as well. And I'm just wondering, so this vaccine was rolled out in 2008. Would you be able to explain a bit more detail into that vaccine and if there's been any development since and changes in that vaccine?
Yeah, so the vaccine that was given in 2008 was a bivalent vaccine, which means that it protects against two of the most important high-risk HPV types, HPV 16 and 18. And together, these two HPV types are responsible for around 70% of cases of cervical cancer across the world. And so this was the vaccine that was initially used. And then around 3 years later, the government decided to instead introduce a quadrivalent vaccine called Gardasil. And this also protects, as well as HPV 16 and 18, it also protects against HPV 6 and 11, which are two low-risk HPV types that cause genital warts. And although, of course, genital warts are nothing to do with cervical cancer, they are a cause of they are a really unpleasant thing to have, really difficult to treat. And so by getting rid of genital warts, that was seen to be an added benefit of vaccinating our children against HPV. And then this year, in 2022, we have actually swapped to an even better vaccine that protects against more HPV types, and this is called Gardasil 9. So in addition to protecting against the low-risk types, HPV 6 and 11, that cause genital warts, and the very important HPV types, HPV 16 and 18, that together are responsible for about 70% of cervical cancers, the new vaccine protects against an additional, what would it be? 5, an additional 5 high-risk HPV types. So in theory, this new vaccine should prevent around 85% of cervical cancers around the world.
So you've talked about this kind of the effects of the vaccine in having a real preventative effect in terms of development on cervical cancer. And I'm just wondering, if it's been administered since 2008, why do people need to be screened if they've had this vaccine?
So the whole idea is that you're vaccinating people before they've ever been exposed to it naturally. So we're vaccinating girls aged 12 to 13, but of course, and now boys as well. But of course, those girls don't become of screening age until they're 25. And so although we have vaccinated quite a lot of young people now, they're only just starting to become of screening age. And so the vast majority of people who are in the screening programme have already been naturally exposed to HPV and remain at risk of cervical cancer. So there's just, the new cohort of people, if you like, coming through that have been vaccinated. And of course, in the early days, they were vaccinated with Cervarix, which only protected against HPV 16 and 18. So that means that there were still around 30% of the cervical cancers would not be protected by Cervarix. And actually, the profile of HPV types in precancer and in cervical cancer are a little bit different. So actually, we do see other HPV types causing precancer of the cervix that the vaccine does not protect against. And we don't know whether or not, if left for long enough, these would be equally as likely to become cervical cancer, because in the past, the whole picture has been dominated by HPV 16 and 18. So people still need to be screened because they still may carry HPV infection that causes cancer and pre-cancer.
Yeah, that's really interesting because I wouldn't have thought about the prevalence of other strains of HPV that would be cancer causing, and that would be the reason that you'd need to get screened. So it's a good message for people to still get screened, really.
And of course, not everybody was vaccinated. So particularly in the early days, the uptake of the vaccine wasn't perhaps as good as it is now. And we've had dips associated with the COVID pandemic that have meant that, far fewer people than we would have hoped have been vaccinated. And actually the way that it seems to work is that those who are at greatest risk of cervical cancer tend to be the girls who are less likely to be vaccinated. So they've done some studies where they have looked at mothers and their daughters, and it looks as if mothers who are themselves not going for cervical screening are least likely to consent for their daughters to be vaccinated against HPV. So you get into a situation where some girls are vaccinated and then religiously go for their screening, and other girls don't get vaccinated and then are still less likely to go for screening. And so, we tend to offer screening for everybody because we don't know what group each individual will fall into.
Yeah, it's really interesting to think about that compound effect of unvaccinated and then not screened. Yeah, kind of puts you more at risk, I guess. And I'm just wondering as well, in terms of the catch-up programme, so is the vaccine as effective if you've already had that HPV exposure?
Yeah, so we don't think so. We think it needs to be before you have any exposure. And the reason for that is that the way that it works is that it causes antibodies that neutralise the virus and prevent it from ever infecting the cervix. So if you have already been exposed to HPV and already have accumulated it in your cervix, so it's sort of lying in the cervical cells, then the antibodies that you produce from vaccination are unlikely to be able to clear the virus because it's already inside the cells. And antibodies work by preventing access to the cells, if that makes sense. So you need a different kind of immunity once you've been infected to one that prevents infections.
Okay, and we talked before as well about this new cohort of people coming through that are those that we saw in kind of 2008 receive the vaccine. Are we seeing that drop in incidence and prevalence of HPV?
So we're seeing a reduction in the proportion of people coming with cervical cancer. So it's definitely making a difference. So a recent study published in The Lancet, I believe, this year by Peter Sassini and his team from King's College London showed that the vaccine has resulted in a 90% reduction in cervical cancer cases in women coming of age, of screening age. But we are still seeing women coming to clinic with HPV-associated diseases. And it could be, as we discussed, because the uptake of the vaccine wasn't perfect, particularly in the catch-up groups. So it was pretty good in the 12 and 13-year-olds, but less good as girls became older up to age 18. But also could be due to an emergence of other different HPV types causing these cervical precancers. So Jen, I think you had a look at this in the literature and you found some quite interesting results.
Yeah, well, I had a look at it actually in the research that we've done, so I'm sure we'll be talking about it. But interestingly, those with high-grade disease that needed treatment, so high-grade precancerous cervical disease, we saw that in fact 99% of those had other types of HPV that weren't associated with the vaccine. So certainly there's a change. There's a change in the type that's causing the issue.
Yeah, so we're still seeing people coming through. Hopefully the numbers are less, but the proportion of the different HPV types seems to be changing.
And do you know of any research groups that would be looking into developing new vaccines for these different HPV strains?
So I think at the moment we are stuck with Gardasil 9. I'm not aware of any that are going to prevent other types of HPV, but there are 13 high-risk HPV types, so we're only covering 7 of those with the current vaccine. So there is room for developing even bigger and better vaccines, if you like. But at the moment, I think we're stuck with Gardasil 9.
Cool. And just as an aside, I'm interested in this concept of a vaccine against cancer. And I'm wondering if this vaccination protects against other kinds of cancer.
Yeah, so that's a really interesting question. So HPV causes other cancers, not just cervical cancer. That's the one that we have been developing it for, of course, because it causes such problems, particularly in low and middle income countries, where it affects young women who are often the main breadwinner and have families, and it's a devastating disease, particularly in those countries where they don't have screening programs. But it also causes other types of cancers. So it causes cancers of the anus, of the penis, of the vulva and the vagina, and also cancers of the head and neck, known as oropharyngeal cancers. And all of these types of cancers are associated with HPV. And although the studies done so far have all been centred around cervical cancer, we absolutely expect that the prevalence of these other cancer types associated with HPV to drop as vaccination becomes much more common in our young people.
Yeah, and especially boys as well. I mean, there's a lot of cancers there that are not gendered.
That's right.
So
yeah,
kind of sounds very important for boys to get vaccinated, really.
Yes, I think so. And I think in the past we thought it was better to vaccinate more girls, more cost effective and more effective at preventing cervical cancer than it was to be gender neutral and vaccinate boys as well. But in the interests of fairness and the fact that boys do develop HPV associated cancers, that policy has been sort of turned on its head, if you like. And so that's the reason why we now have a gender neutral vaccination policy, because we want to be fair.
Yeah, it's a really nice progression. And I guess we've heard about the prevention of cervical cancer through HPV vaccination from you, Emma. So I'd like to move on to the early detection of cervical cancer. And Emma, I know in 2020 you received funding from the NIHR, which is the National Institute for Health Research, for a 5-year advanced fellowship to investigate whether urine testing can be used to screen women at risk of cervical cancer. And Jen, I know you're working on this project with Emma, so I'd like to come to you. And I'm wondering, firstly, if you'd be able to explain the importance of cervical screening. And I know we've touched on it with Emma, but I'm just an
overview. So screening came about in the sort of late 70s, 80s in the UK. And we know that from big studies that it's reduced the number of those dying from cervical cancer by up to 70%. So it's definitely made a difference. So that's the importance of it. And we also know that in high-income countries where we have screening programs, such as what we have here, luckily, we certainly have lower numbers than in low to middle-income countries where people just aren't being screened. So it definitely makes a difference and is important.
Okay, and I've read that only 70% of people eligible for cervical screening attend their appointment here. Is that in the UK or England?
That's the whole of the UK.
Okay. I'm wondering if you could explain the current screening methods and some of the barriers to cervical screening that currently exist.
So the way that we screen is the same way that we've always screened, pretty much. So you have to have a speculum examination to visualize the cervix, and then a brush of the surface of the cervix is taken with some of the cells taken in that sample. And then what's recently changed and is in 2019, we started to test that sample just for the virus, HPV, so the high-risk types, whereas before we used to look just at the cells, but we found the virus to be effective, to look for the virus more effective than just looking at the cells. And then if you're positive for the virus, a high-risk strain of the virus, then the sample is then looked at from the cellular perspective to see if there are any abnormalities. And then based on that, you may be having further investigation. So that's the way that screening works currently. Essentially, that obviously requires you to go to your GP practice to make an appointment, to then obviously take time off work. Often, the screening program is for younger people, so between 25 and 65. They'd have to take time off work, go to the GP practice. So that's one of the big barriers is access or making that appointment and finding time. And then the other barriers are understandably going to be the embarrassment of having that examination, an intimate examination like that, and also the discomfort or sometimes the pain that some people experience having that examination.
I'm wondering if you'd be able to tell the listeners about some of the research activities that you're currently doing that are taking place to address these barriers.
Yes, so my project with Emma is looking at whether we can get rid of the access barrier so people can do a test at home, and whether we can also get rid of that examination. And that would be through a self-sampling method. And we're specifically interested in looking at urine testing. Urine is something that people generally have no issue giving a urine sample. It's quite straightforward. And we're investigating whether that urine sample can actually pick up the high-risk HPV if that individual has it, and whether that could be done potentially at home and then sent in and then tested for.
Jen, what is ACEs?
So ACEs stands for Alternative Cervical Screening, and one of the first tasks that I was tasked with by Emma was to come up with a good name for this urine HPV testing study. So we did come up with ACEs.
Okay, so there's the kind of looking and seeing if this urine sample can be used and is it as effective as the previous screening method. What would you call that screening method? We don't call it smear test, do we?
Cervical sampling.
Cervical sampling, wow.
Bit more of a mouthful.
Yeah, it is. Bit cumbersome, but we'll go with it. So that's the number one kind of prong of this research. And then I had the great opportunity to attend an event with you last week, and that was looking at access for all in the LGBTQIA plus community. And I'm wondering if you'd be able to explain the kind of acceptability parameters that you've been investigating, because it's a really great study. I've loved hearing about it, and it's one of those things that every kind of single update I get excited about it. So please, can you just tell people about it, because it's fab.
So that's great. I'm really pleased that you like it. I do too. But
I'm glad you do.
But essentially, I mean, we're looking at an alternative test to see if we can get more people tested and potentially also get testing started in places where, it's too expensive to have the kind of testing that we're doing currently. So in low to middle income countries. So that's sort of what we want to do. But the thing is, we need to know that it's actually going to increase the numbers of people being screened, because there's no point in looking into it if it's not going to do that. So the acceptability bit of it is really to see whether people think this is a good idea and whether it is likely to increase the numbers of those going for screening. And we looked at the LGBTQIA plus community because there's no research being done in this community within Manchester in early cancer or prevention. And also it's a really important group to look at with regards to cervical screening, and especially those individuals who identify as transgender. It's really important because we know that the likelihood is this community is not going for screening as much as other people. So that's why we looked at it.
Yeah, I mean, I found it really interesting that we talked about barriers to screening in that community in specific, and even just things such as gendered waiting rooms. And if you're a trans man, sitting in a female gendered waiting room could be very stressful. So then the acceptability side of things, of saying, okay, well, if you don't have to go through that, because unfortunately sometimes society isn't as accepting to people as you want it to be, if we did give you this at-home urine test, you could use that and just send it in and kind of eradicate the need for going into the GP, which I think, I mean, I know you spoke about the results looking really positive, but that it's a great pathway for people that feel discomfort associations with our kind of current healthcare system.
Absolutely, yeah. The only thing is it can't replace us looking at those barriers, because these individuals also need to feel comfortable accessing their GP and care for other things. So we need to be careful that it doesn't completely replace that, or is a way of making people not look at these other things, which are also really important. But I think awareness is key here. But if it can increase the number of people being screened, then that's got to be a positive.
Yeah, definitely. And I know you spoke about this at the event, but for the kind of benefit of the listeners, so urine is really useful. We use it for STI tests and kind of various tests to look at kidney function, liver function, etc., etc. And I think one of the things with cancer is, and I know you kind of look at this with Phil, Emma, on teaming up and looking at multiple cancers rather than one, because if you've got kind of a patient in one location, you might as well test for everything while they're there. Do you envisage the development of that test to not only look at HPV, but maybe even integrate some STI tests into the sampling?
Absolutely. That's definitely something that can be done. That would require, I guess, a concerted effort from industry as well, because obviously the testing is done by companies who have their own platforms for testing. So it'd be really important to work with them and potentially across the industry to try and come up with a test like that. But I think urine is definitely looking positive as a method of screening for potentially lots of different cancers and also other infections.
Urine is the future then.
Absolutely.
Well, yeah, if we can minimise the number of wheeze and pots and use them the best that we can, I'm sure that'd be great.
although there's generally plenty of urine to go around.
Yeah, that's one of its benefits, isn't it?
Yeah. And if you run out, you can just produce more.
Yeah.
Well, I'm just wondering, this is kind of looking to the future with you both, utopian environment. It's, Jen, you're laughing, but it's going to be utopia, don't you worry.
A urine utopia. It has a ring to it.
We'll coin that, urine utopia. Absolutely
I love
it.
Crosbie's urine utopia.
Now I like it even better.
Although now we have to say Emma Crosbie's.
Oh, yeah, it's true.
It's got a ring to it. I love it. The golden era, if
oh,
you
no.
will.
We're taking it too far.
All right. Okay. So Manchester has a large and engaged LGBTQIA plus community. And is this one of the reasons why this trial or survey component is being conducted here?
I think it came from individuals within the Christie and sort of came together and said we should be doing something. The urine study looks interesting, and we should be looking also at being more inclusive in our research, because we know that this community is not very engaged with research, unfortunately, for various reasons. So that's why it came about. And of course, Manchester is a big hub for the LGBTQIA plus community, so it was a perfect place for us to address this issue, and with also looking at larger numbers as well. But because it was an online survey, we actually got a lot of data as well from London, which you'd expect, and some other places in the UK as well, but less so.
And can I just ask about the results of that survey as well? So am I right in thinking you had 550 responses?
Yeah, 503.
Ah, close. 47 off, but I'm going to take it as a win. And what was the composition? So you went out to the LGBTQIA plus community. You said, please, can you fill in the survey on acceptability? And what were the responses like?
So first of all, it was interesting because we did get a high number of individuals who identify as transgender, which is fantastic because obviously there are less numbers of people who identify in that way than there are, for example, lesbian or bisexual individuals. So that was fantastic, and essentially it showed that there would be a high acceptability. And obviously we're talking about acceptability when people just hear about the test. They haven't actually undergone the test obviously yet, but when they hear about the test. But there was a really high number that were very happy to do screening in the future with urine. And we also asked them about vaginal sampling as well, because that's another method of self-sampling. And that was also a lot more accepted than obviously cervical sampling, which requires you to have someone else do that test for you.
And has vaginal sampling been tested for efficacy?
Yes, it has. It's a bit more forward in terms of it's done a lot more progression than urine sampling. But yes, it's just as good at picking up HPV as the cervical sampling. So, and there are 2 big studies happening in Manchester and also in London in the general screening population to see whether we can do vaginal sampling in the future. And I think, it's safe to say that the likelihood is that will be available in the coming few years in the UK. It's available already in 9 countries in the world as their primary cervical screening method.
Oh, really? What countries do you know?
One is at least Sweden, I know. Probably all the Scandinavian countries, I'm pretty sure they're pretty forward-thinking with these things.
They are progressive.
But the reason that we thought that urine would be even better is that the studies so far suggest that although vaginal self-sampling is acceptable to some people who don't go for cervical screening, it by no means gets over all the different barriers. So some studies in the UK have looked at specifically targeting people who haven't gone for screening with vaginal self-sampling and had a really bad response rate. So, the majority, the best they could get was about 20% response rate. So that means that it isn't addressing the barriers for the other 80% of non-attenders. And we think that that's probably because it still requires an intimate examination. And, there might be personal and embarrassment and cultural reasons why that isn't acceptable to some people. But as Jen said before, people are familiar with taking a urine sample, and hopefully that will help us to develop a test that's even more acceptable to people. And I guess ultimately the plan is that if we can offer choice to people, so, it might be that some people prefer to go for cervical sampling because that's what they're used to. They've perhaps have abnormalities in the past and they feel safe continuing with physician-collected cervical samples. There are some who, are very comfortable with taking a vaginal sample, and that might be their preferred method. But there will be others for whom urine would have more acceptability. And so the idea is that we want to give choice.
Fab. And Jen, just back to kind of your work, your ACEs work. So have you been to Somaliland or you're okay?
It's not part of ACEs.
It's not. Oh, that's awkward.
It may be in the future.
Yeah, I mean, ultimately, we want this test to be useful, not just in the UK, where we already have 70% of people going for screening. We want it to be useful in other countries where they perhaps don't have a screening programme and where there are even greater barriers to screening, like the cultural things that we were talking about. And so I think you had aspirations, didn't you, to go and try it in somewhere like Somaliland or Kenya or, some low middle income country where there isn't an established screening program to see how well urine sampling would perform.
I guess the other thing, there are other issues with going to a place where there's no screening program in place, and that's the infrastructure. So what do you do with a positive test? So those are the big questions and the big barriers, I guess, for us researching, is to make sure that it's adding benefit to that population and not just finding out if people have HPV or not and then not being able to do anything about it. So that's really important.
Yeah,
as well.
Ethically, it wouldn't feel right to go and find a whole load of people with high-risk HPV infections and then there was no opportunity for them to be, have further investigations and treatment. And we know that that is a problem in some of the countries that we're talking about. So, there needs to be more than just a new sampling method. But, this could be one small step that helps the other things fall into place.
Watch this step.
Watch this space. I'm seeing you go worldwide. If I'm honest,
that'd be nice.
The global urine utopia.
We everywhere. Don't we everywhere?
No, it's okay.
So coming back to the UK. We'll talk about the global utopia in a bit, but coming back to the UK, what are your next steps, Jen?
Oh, gosh.
Big ones?
So we have looked at... So the main thing that I've been doing with Emma is looking at whether urine tested for HPV is picking up people with high-grade cervical disease, so that pre-cancer, that need treatment because they're at risk of developing cervical cancer. So we've looked at a group at St. Mary's. So I've collected a lot of urine. So I'm very well versed in that now. And so hopefully we will be able to share those results in the near future. And we are also, the ACEs research is also continuing into the screening population. So we are currently undergoing the primary care arm of the study.
Yeah, those two things are really important, aren't they? So first of all, it must pick up the high-grade disease. We need to be seeing those women and offering them treatment. But it also needs to safely reassure people who don't have the HPV. So you need to look at a kind of an enriched population who've got the pre-cancer to check on the first thing, but then you need to look at a low-risk population, a general population, to look at the second. And so it's this combination of the two settings in the colposcopy clinic where there's lots of pre-cancer and in the general population where there isn't, that will help us to see, actually, is urine good enough? You're also testing it in people who've undergone treatment for pre-cancer.
Yeah, so 6 months after a treatment, you have a cervical sample taken to see whether you've cleared the virus, and that's, if you have cleared it, then that's essentially means the treatment was a success. So we're also collecting urine in that group of women to see if the test works just as well in that population, and whether also it would be acceptable to people who have had a treatment for abnormalities to then have a urine test instead of a cervical sample as as their test of cure, so to speak.
And then after all of this, once we know that it actually works, the plan is to see whether it helps people who haven't attended for screening to actually go for screening. So the plan will be to find people who have not attended routine screening and send them a self-sampling kit to their home address and ask them to return a urine sample to the lab, and then we will be able to see whether it's appealing to them, whether it helps people who haven't been screening be screened. And because we're also going to be directly comparing response rates with vaginal self-sampling in that group, we'll be able to directly compare how well urine is working compared to a vaginal self-sample, compared to doing nothing at all and allowing people to just eventually turn up for routine screening if they wish to. So that's really quite an exciting study. We're going to look at about 10,000 people, and that'll be in the year 2024, I think. But yeah, that'll be really exciting. But clearly it's only worth doing that if we know that the test genuinely works. So watch this space again.
God, you guys are so busy. Do you sleep?
No.
She's not allowed to sleep. No. She's doing a PhD.
Not allowed.
Fair enough. I'll do some sleeping for you. Jen, you're from Wales.
I am.
What's brought you here?
Emma. That's it. That's all I need to say. One word.
God, Emma.
I've left my home country.
For you, Emma. All for you.
Well, for the research. I think it would be fair to say. But I think Jen could see that this was a great opportunity, because it was on the back of the NIHR fellowship that I had received. So we had money to do, a really good study. And yeah, I mean, just very, very exciting. The general public were really sort of buzzed by the idea of a urine alternative to routine screening. So it was just riding that wave, wasn't it? Yeah. Of wow, this looks exciting. Let's study it further.
Yeah, there's a lot of positivity.
Yeah, well, yeah, I've personally kind of met your research group, and God, the gang is just amazing.
They are.
Makes you want to be part of the gang.
Oh, well, you're part of it.
You're very welcome. PhD opportunities coming out.
I'd like to look into the future with you both. And the World Health Organization wants to eliminate cervical cancer by 2030. And I'd like to put the question to you both. What are your ambitions for cervical screening by then?
I mean, there's only 8 years until then.
It's not long, is it? I mean,
no.
To be honest, the UK is doing pretty well. It's about increasing uptake of screening. It's about making sure we continue to vaccinate all the young people that are eligible. And it's about there being access to treatment. So we are doing really, really well in the UK. There are strict targets that we have to meet, but I don't think we're far off them. The issue isn't here. The issue is other countries where just none of that stuff is in place. So there is nothing to protect people who've already been exposed to HPV from cervical cancer. Those who develop cervical cancer often therefore develop it at a more advanced stage where treatments aren't as effective and sadly aren't as available, so they just don't have the opportunity to treat women with advanced disease in the way that we have here. And the vaccination programs are starting, but it hasn't been in place for as long as it has in this country. So they are significantly behind. And I guess for both of us, the ultimate ambition is to try and correct some of those global disparities. It's all very well to make screening a little bit better in the UK, but we're already doing quite well. It's how do we reach those other countries where women have no access? And I suppose that's my ambition. I think it might be yours as well.
Yeah, sounds familiar. Yeah, I think it goes beyond those screening, looking more at the disparities and the services that people have in low to middle income countries. Unfortunately, even if we, as I said, even if we find HPV or if we find high-grade disease, it's then the treatment of that and the follow-up of that. It requires a complete overhaul of systems that are probably already not in place because potentially definitely a lack of funding, and also a lack of political will, and just the fact that people in their life, they live very different lives. A lot of it is about survival, and putting food on the table rather than thinking about going for screening and making sure that you're not developing cervical cancer. But nonetheless, really important. And if we can change that or make it a bit easier, and at least start that process or ball rolling, maybe that will then lead to some change.
I'm sure it will. You're making great leaping steps. Thank you so much for coming on with me. It's been an absolute delight. Love hearing about your research and what you guys are doing, because it's always amazing. Maybe I'll join the team one day, who knows?
Very welcome.
Yeah, please do. We'd love to have you.
Thank you as well to our listeners, and I'll tag both of your Twitters if that's okay.
Yeah, sounds good.
Of course.
Because, Jan loves a selfie.
I do.
And Emma loves Twitter also. So
I never heard of Twitter before I met Emma, so
you need to get
my
on
world
Twitter.
has changed.
You need to know what I'm doing. I announce it here first.
Emma's prolific.
So I find out about the next projects I'm doing from Twitter.
She does.
Blooming typical. Yeah, we want food updates as well. Everything that we can get. But yeah, we'll link all tags. I'll link all their kind of amazing work. We've got a lot of links and a lot of MCRC blogs as well. But yeah, thank you for listening, and thank you guys, and have a great day. If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.